The broadcast is now starting. All attendees are in listen-only mode.
Are we good?
We are good. So we will just hang out a few more minutes before we begin. Thank you, Dr. Kim.
Very welcome.
Hello, welcome, and thank you for joining us. I am Rachel Moody, the Marketing Director at Millennium Dental. Before we begin today's webinar, there are a few housekeeping elements that I would like to address. First, questions can be asked at any time using the questions box on the webinar screen. We will gather all the questions and address them at the end of the presentation. If you have any sound issues, please try connecting through computer audio. We have found that this platform does work better using computer audio versus your dial-in audio. And an hour after the conclusion of this webinar, you will receive an email with details to claim your CE credits. This email will be sent to the email address you used when you registered for the webinar. Today's webinar, When Saving Teeth is Your Priority, is presented by the esteemed Dr. Jin Kim. Born in Korea, Dr. Kim grew up in Sydney, Australia, where he attended the University of Sydney Faculty of Dentistry. He furthered his education with an advanced degree in pathology from the Medical School of the University of Sydney, graduating with honors. Dr. Kim settled in California, where he completed master degrees in public health and oral biology, and then his residency training in periodontics and implant surgery at UCLA School of Dentistry. He is board certified by the American Board of Periodontology and the American Board of Oral Implantology. He is a fellow of the International Congress of Oral Implantologists, as well as a fellow of the American Academy of Implant Dentistry. Dr. Kim was LANAP trained in 2011. Welcome, Dr. Kim. It is a pleasure to have you here with us today.
Thank you, Rachel. Thank you very much. It looks like this is the last of the series that Millennium has been putting up. And the 6 panel speakers that you see on the screen are one of the greatest people. I know every one of them fairly well, and it's just a simple honor to be on the same page as these individuals. As introduced, I am a UCLA guy, but hey, I gotta show you this. If you can see this, this is my only affiliation to USC. My wife is a USC graduate. My son went to USC undergrad, so that's the extent of USC connection for me. When we started this unusual time, early April, the pandemic didn't really, we didn't really quite know where this was going. As of today, the tragic situation is this is still not fully controlled. We are still in a danger zone. and we truly all wish to get back to work as we all do, and treat our patients what we do best. Just like this pandemic, I want people to start thinking, well, we should look at periodontal disease kind of like a pandemic. Although the media doesn't really rally behind this as in other issues. Almost half of our population, and be it the United States or any other modern society, has a significant amount of periodontal disease. Just on the side, periodontist or not, general dentists and dental professionals, take a look. Unfortunately, the highest risk in this day and age is the dental hygienists, some people that we rely on the most. And these are our workforces, our worker bees that do the bulk of the work in treating and preventing periodontal disease. So, in a way, it's very, very sad. Dentists fall into this box, upper right box. Dental assistants and dental hygienists fit in here, registered nurses. Times like this, you wish you were, let's say, web developer. Marketing specialist. Hey, there you are, right, Rachel? Marketing specialist. These people are relatively safe as opposed to the dental hygienists, assistants, and general dentists. So let's go to this health spectrum. We all understand there's this wide spectrum between health and disease, and our job is to take our patients, with whatever the area of expertise you are, and take them to the wellness aspect. This concept was proposed by John Travis, a public health individual. Now it is the most recent definition of this is the well-being is many things that we already understand, including managing stress. Times like this, stuck at home, trying to see when you're going to go back to normal. It is a source of stress, both for us and for our patients. So we know that gum disease, really don't want to trivialize it. It has a bodily connection, and this connection of systemic condition has been talked about at depth in the past decade or two. Let me just point out one paper that might be of more relevance in this time. It's a relatively recent article from 2017, a group of Japanese researchers. What they have found, they looked at postmortem studies of people who passed away with pneumonia and hemodialysis group, and they found a significant number of them actually had periodontal disease. In other words, the correlation between the ones with active periodontal disease at the time they passed away, there was a 3.5 times stronger association. What does that mean? Can we interpret existing data like this to say COVID-19, for instance, that has a predominant predilection for pneumonia and lung issues? Can our patients who are in this category, and supposedly if they have uncontrolled periodontal disease, are we putting it at much higher risk, especially in this post-COVID era? So let's put that into perspective and see how we can help our patients. This gentleman came to my practice with this comment. You'll hear his testimonial in a minute, but he was afraid that he was going to lose many teeth. When you look at his mouth, that's clearly periodontal disease here and there, not as bad, but his lower incisors were in trouble, and he was in fact told that he will lose those teeth. So by the time he came to my office, he was not very hopeful, yet he wanted to see if the laser would make a difference. So here is the preoperative cross-sectional views. You can see a significant amount of calculus, but you can also see that attachment loss and clinical bone loss, at least in the radiograph, is significantly lower. The teeth were also in malocclusion, and the hygiene clearly needed some improvement. This is immediately after the debridement and periodontal therapy. You can see that the incisal edges of the teeth have some wear marks, and they're relatively level. In fact, they're quite shorter than they had presented earlier on. So needless to say, some sort of active therapy, occlusal correction was in place. And further down, What I did was splint those teeth to immobilize them, just like what we do in implants today. Immobilization is the key for proper osseointegration, which is a philosophy that orthopedic surgeons have known all along, which is what periodontal field has known all along, except there has not been that much of an emphasis on the occlusal aspects of periodontal disease. And I think we are getting better at it, but there's still, one of the frustrations that I personally have is people are not as aware of the occlusal interactions or, negative interactions with the periodontal health. So here is the case that is completed with rigid splinting, extracoronal splinting, and here's what you want to know. For those of you who are kind of relatively new to this is a schematic that you will see in many places of how a laser assisted new attachment protocol, namely the NAP, is understood. You get rid of the calculus, which you can do with many different modalities. The laser tends to enhance that, and it gives you a little more higher degree of perfection than you would go through with rigorous scaling and root planing, which is nothing new. Now, what might be different that people may not realize is you go in, and as this cartoon figure describes, you tend to subclinically damage or stimulate that crystal bone, the base of the periodontal pocket, to try to stimulate bone for repair process, which is something very similar to what we do in implant dentistry, regional acceleratory phenomena. And that in turn creates platelet wounds to form, very synonymous with the platelet-rich fibrin therapy that is very commonly done in today's world as well. And to make sure that that becomes stabilized, the laser is again used for the second time, the first pass, the second pass, and in this time it stabilizes the wound, forms a clot, forms a nice stable base with relatively little mobilization, which then helps the healing, minimizes the recession, minimizes tissue loss, and hopefully regeneration happens. And what is very important in this protocol, and I must give the Periodontist and Millennium people full credit for this because I think their emphasis on occlusal reduction and occlusal calibration is something critically important in this process that is not well understood in general. And as a result, if you get immaculate regeneration, that's what we want. And because of that history, the company has recently been given this, go ahead from the FDA of this new term, LAR, as opposed to LANAP, laser assisted regeneration. We can truly say, yes, we are creating regeneration using this methodology. So in this gentleman who I followed up at this point for just under 2 years, we did not get all the attachment back. We did not, but we saved his teeth. And carefully, if you look at the lamina dura compared to the pre-op, we've got very, very good return of lamina dura, indicating that now this is very synonymous with health. So with the lack of inflammation and return of health, we tend to get this beautiful lamina dura formation.
I went to a dentist that told me that if they clean my teeth, that my teeth would probably end up falling out. My teeth were so bad. And I really thought I was going to lose my teeth. But I was fortunate enough to get referred here. And Dr. Kim and everybody here has been awesome. I went through a surgery that really saved my teeth. I like to smile now. And my teeth feel great, and I'm glad I came. It's been a godsend that I'm here, and I'm happy. I recommend anybody that thinks that that they there's no hope. There is hope.
So there is hope. Interesting comment, and cute how he showed his teeth. So we're in the same periodontal disease. This is something lay public tends to even understand, relative progression. Let's just ponder here for a few minutes. I would like to update the audience on the newest periodontal disease classification. This only happened just a few years ago. Prior to this, we were relying on the 1999 workshop, which gave us this classification that we lived for more than a decade. And under the old category, we had four groups: aggressive periodontitis, which literally meant we couldn't figure out what's going on. It's just a very fast progression, and then we just threw it into that box. Chronic periodontitis was the vast majority of the everyday bread and butter cases we saw. And then there was a special subgroup called the necrotizing periodontal disease, the ANUG, as you well know, acute necrotizing ulcerative gingivitis, the punched out papillae that you saw in stressed out people associated with smokers, mainly associated, we speculate AA and certain types of bugs. It seems to have vanished. Nobody seems to be seeing that in the clinical situation. So at this time round, this disease category was eliminated to my satisfaction. And then the fourth one, the manifestation of systemic diseases relative to, let's say, immune compromise, cancer victims, and whatnot, is a very special subcategory that we tend to see. Now, the severity is very simple. In my practice, I try to describe in lay terms to our patients. Say you got medium, small, medium, and large. Small amount of disease, moderate amount, and lots of advanced diseases. How we typically translate this information to the lay public, namely patients, and models like this become very handy in doing so. And then there's the distribution. The distribution is considered to be localized if it's 30%, roughly one third of the size. If it was more than that, we threw them into the generalized box. So let's get back to this guy. This gentleman came in. He was nervous. He was scared that he was going to lose teeth. But when you break this down, the type, the severity, the distribution, when we break it down, he had generalized early to moderate chronic periodontitis. He actually had significant attachment loss here, so we can then say, yep, that's localized advanced chronic periodontitis. Very simple and easy. So what has changed? The classification that has changed in 2017, we combined effort between Academy of Periodontology, the American Academy, and then European Federation of Periodontology, almost 200 clinicians. First of all, they got rid of the aggressive box because they thought that just confused everybody. Yeah, you assume. They got rid of the necrotizing. Now it's periodontitis. However, we added staging and grading. Staging is pretty much similar to what we had, but it goes into a little more uh, detail. Staging in cancer is well known. Everybody knows when somebody says, I got cancer, what stage are you at? It's a very, very easily understood communication tool in the medical field. So staging of breast cancer, colorectal, different types of cancer is a well-known fact. So that's the part that was added to the periodontal disease classification. And then the second part is grading. This one gets a little bit murky and a little bit strange, so I'll have to explain it in a little more detail. So as far as staging is concerned, it's just mild, moderate, severe, and very severe with a little bit of qualification, which I'll go into. So you can do this based on clinical attachment loss. The traditional way, we probe each and every 6 sites. Therefore, you can come to the clinical attachment loss of 2, 3 to 4, 5, and so on. But remember, this is clinical attachment loss. In other words, the reference point is the CJ, not the free gingival margin. If somebody has gingival hyperplasia, overgrowth of the gingiva, and the gingiva is way up into occlusal level, you're going to have artificial or what we call pseudo pockets. We don't count that. We want true attachment loss. So that's the way we count it. And then another way to look at it is based on radiographic assessment. So this is the same patient, our Marco again. When you look at this, radiographs, some of the teeth are way down there, but some of the teeth, of course, are within 15, 20%, 30%, middle of the root, or beyond. Of course, this is not Marco. This is our good old COVID-19 tooth. I'm just kidding, but when you have calculus that far, it certainly does look spooky, like a COVID virus that we're very familiar with at this point. So the staging is also, so there's a clinical attachment loss, the radiographic, and also based on number of teeth or tooth loss. So when there's no tooth loss due to periodontitis, you're probably in the stage 1 or 2. If there's more than 4 teeth, up to 4, we call it that should be stage 3, sorry. And then if you have 5 or more, then you're at the far extreme. The grading. The grading talks about the rate of progression, responsiveness to therapy, and also impact on the systemic health. So let's dissect this. Let's talk about the speed. So grade A, B, C is how fast the disease progresses because we know everybody reacts differently. So grade A, the way to understand this, and there is a special way of calculating it. I guess Asian doctors are at an advantage because we know how to do calculation, multiplication, division. So when you divide age, bone loss, the amount of bone loss is divided by age, we kind of get a proxy as to the level. So let me give you an example. If a grade A person, if untreated, will lose 30% of the bone. Whereas a grade 2 person, by the age of 80, if no treatment was rendered, you are expected to lose almost all the bone. And if it was grade 3, the fastest rate person, you would be expected to lose all teeth by age 60, not 80. So that just gives you an idea of the speed of progression. And you can modify the risks, and the two big factors are, you probably guessed it, smoking and diabetes. So if somebody does not smoke, then you are automatically grade A, the low progression. When you smoke more, up to 10, more than 10, we go into this higher grade category. And the second big one is the diabetes. When somebody has a hemoglobin A1C of under 7, lay interpretation of is relatively well controlled, depending on who you talk to, then it's still considered moderate. You have diabetes, you are at the moderate grade modification. But if you are so-called uncontrolled, in other words, more than 7, you're in the worst category, worst grading category. So the way some of the rules that are here, you take the worst tooth in the dentition and you apply that to the grading. And in general, you go to the mid-level, grade 2, and then you look to see if other evidence shifts you to better or for the worst. A couple of other interesting things that changed in the new classification is that the term excessive occlusal force is now changed to traumatic occlusal force. Not a huge big deal. Another thing that might be of interest, not many people know this, the so-called biological width. And you could argue, how could it be biological width if you're talking about the height? Arjulo said almost 3 millimeters. Yep, well, the height. So they got rid of that term altogether, and now it's called SAT, supracrustal attached tissue. Some of the interesting trivia. Okay, so let's look at another lady. Michelle comes into my office, pretty similar sort of a mindset. She was afraid she was going to lose the teeth. And look and see the amount of bone loss on the two central. So that will be, grade 2, severity 4 under the new classification system. And truly, when you look at this, you say, boy, partial dentures, do we do implants? So let's see if this technology that we have, using the laser and using all the current parallel knowledge, we can save our teeth. So first thing I did was these teeth were super runted, and as a result, there's pathological splaying as well as excessive traumatic occlusion, you can imagine. So the pencil lines that you see here is my rough idea of how to trim the teeth to get it back into normal occlusion. In fact, being in the front area, especially with a person who is so paranoid, I had to get her on board. So it was a method of drawing, letting her look at the mirror, just showing the photograph, dissecting, and say, will you be okay if I trim those teeth to that level? And of course, she came on board. She was agreeable to that. So now I'm carefully looking at the occlusion to try to keep it as close to the ideal with minimum lateral protrusive or protrusive trauma. We're trying to keep as best of an occlusal scheme. And you can see this mouse is a mess. We have pocketing everywhere. So this is a grade stage 3 to 4 with grading of 3, A, B, and C so far. So that's the way she presented. This is pretty much right after LONAP was performed. Now, of course, with any parallel therapy, be it surgical, non-surgical, laser-based or not, we are going to have some tissue recession. Now, of all the methodologies I've used so far, and I've been a periodontist for just over 20 years now, of all the methodologies, flat techniques, regenerative techniques of one sort or another, the laser-based and so on, we see the minimal amount of tissue shrinkage with the laser. There's no question about that. So for this patient who had this concern, clearly this was the better approach. So this is just side-by-side comparison of the pre-operative and immediate, when I say immediate, several weeks after LANAP was performed. And at this point, when we had some confidence that we were going to keep those teeth, we decided to do some enhancements. Two things. I wanted to further stabilize the occlusion with meaningful canine guidance, but also close up the gaps and black triangles, which was more of the patient's desire. So as you can see here, this is bonded resin glued on to the lingual aspects and to the interproximal aspects, doing the best that I could. I mean, this is a periodontist aesthetics, okay, not the skilled restorative dentist out there. This is a periodontist imitating you guys. But nonetheless, the result is this: minimize the black triangles to the point where she was quite happy and was acceptable. The main central incisor black triangle was reduced from something significant to as minimal as possible. So here we are. 4 years later, the teeth are still in function. She is able to perform lateral choosive bite into food and relatively normal function with good hygiene. And this is the way she is.
Michelle?
Yes.
Okay, so why don't you tell me a little bit about how you feel about the treatment that you've received here at Dr. Kim's office?
Oh my gosh, it's been amazing. Dr. Kim saved my teeth. I was told by my dentist to run, don't walk, to find a periodontist. Something serious was happening with my bone. I had lost 50% of my bone in a year. And he said, so in another year, you'll have no teeth. So I went to, I got a couple referrals. I went to a different periodontist first who told me there was not going to be, there was going to be a bunch of teeth lost. And then I came here to Dr. Kim, and he said, not only are we not going to lose any teeth, we're going to grow some of this bone back. And he explained the procedure. I did some research on it. We scheduled the surgery procedure. I was skeptical because of the research I had done and how serious my bone loss was. Anyways, we did the procedure. I spent 3 days at home relaxing, not wanting to drink or eat anything. And I guess right now my teeth are amazing. They've been saved. I've grown bone back. It's a miracle. And I'm just so grateful. So there you have it.
So clearly, we were able to bring that patient from an ill perception, situation to the wellness, and it's critical that the patient come on board. You see, it's proper diagnosis. You need to co-discover. The two examples I've given so far, they came in with the full knowledge, scared. They were the ones saying, "Doctor, help me. I want to save my teeth." So didn't require a lot of co-discovery. But some people don't have that mindset. For instance, how many people have you seen the patient and said, you have gum disease, and they look at you like, are you talking to me? This patient, for instance, was referred in for a recession defect, which is a good call on the referral's part. You can see the mucogenital defect. Some heroics to try to hold on to that too. So it was traumatic occlusion, secondary to orthodontics. But when I examined the patient, I said, boy, we've got bone loss everywhere. So we've got some serious periodontal disease. And I said, you're bleeding everywhere. You've got gum disease. And he looks at me like, what are you talking about? So then I had to convince him. I can't just talk to him about, how much bone disease and so forth. Well, many times a good method is simply to take the sample from their mouth right there and there and put it on a slide and let them watch. It gets to the point where patients say, that came from my mouth. So sometimes I have to do this like a magician does. See, now I got nothing coming in. There's no trick here. I just take the sample, put it on the plate, and then I have to then share this with the patient real time, right in front of them. So my microscope is typically in the front. This video is you can check this video out if you use the keywords Jin Kim periolace microscopy. You will find this, and this is what I did one day with my assistant. Actually, this was a real sample. And in real time, my assistant was videotaping with my iPhone, and you saw the activity of all those spirochetes. We were literally spinning and doing all sorts of dance moves. And all of a sudden, with a single stroke of the periolace directly onto the sample, virtually most of them were dead, which is incredible. So this type of co-discovery is helpful in many, many situations. We, of course, have to explore all the options, let the patients own their problem, and let the patients decide. All we do is facilitate those options. And then whatever the barrier is to treatment, be it fear, cost, whatever you can identify, we'll try to work with the patient to minimize it. And then, many times you need to use the best expertise that we have possible. So this traveling in this journey from disease to parallel health, this device, in my opinion, has helped me significantly. I was a skeptic. I'm going to be very frank. When this first came out, I said, really, really, they can do that? So I sat on the sidelines for a significant period of time. And the only way I could convince, I could not honestly could just believe their brochures and fancy statements and whatnot. I actually went to no less than 6 practices who were utilizing this. Not just anybody, some people that I truly had a lot of respect for all around the country. And, based upon my experience, I said, there's something to it. I better start looking into it. And so I jumped in. This is a statement I'm going to make because a sales pitch typically could sound like this. Your practice is not, doing well. It's slow, especially post-COVID. We're going to be in a mess. You fill your rooms, fill the production, buy this device, you can get return on investment. Yes, I don't mean to sound, too negative, but that's typically how sales are done in many, not just us, but many dental equipments and so on, and just to give confidence to the customers. But truly, this is what I want to say. Whenever people ask me in person, I said, look, you will use that technology, and there's no question about the technology, but you need to be ready. You need to have the clinical skills. You need to be true to the fundamental principles, and you need to have a practice that's willing to go on this path with the patient. Without that, don't just buy the machine. You will be making a mistake. Let me explain that in a little more details. This is 1998, clearly way before laser was in my office, but I just wanted to bring some of the principles. 55-year-old patient, smoker, came in. She did not even realize how bad her teeth were. She just simply came in because I want to have some back teeth. I want to be able to chew better. So she was more led to the implant therapy. In fact, she came into my practice having heard me give a small community talk about dental implants. So when I first looked at her, I said, yes, you need implants, but let's treat your gum disease first. And again, just like many other patients, she looks at me and says, what do you mean gum disease? I don't have gum disease. And took a lot of convincing to say, yes, you do. So after she came on board, this is traditional non-surgical therapy. Just to throw some evidence at you, this is Paulo Camargo and his group. Paulo is the chairman of Perio at UCLA, brilliant clinician academician. So let me just give you this as a very, very strong piece of evidence. Somebody with that much bone loss, with or without laser, this is an uphill battle. And you would imagine many of these to be taken up. Guess what? This is a case that they did 6 years follow-up and a 12-year follow-up, and they have kept every one of those teeth. So non-surgical periodontal therapy does work. You have to be good at it. Not all of us have that skill level. You have to use the right armamentarium. You have to be very skilled. You have to be very patient. Patient has to be patient. But that's where our misdeeds are, because sometimes we're not patient enough. Take a look at this case. It takes meticulous amount of work to instrument things right. Your hygienists will tell you they need a lot of time and effort to be able to pull this through. And you need some specialized instruments, fine curettes, and skills and experience to be able to do this. This is not easy. But if you look at this, this is one part of the LANAP protocol. And of course, I'm not downplaying LANAP. This is a very important part because many people take the expensive laser device into their office and think you don't have to be true to these fundamental principles anymore because now I've purchased this fancy dance machine. This is a good example. I show this a lot in my presentations. This is a case where a patient received non-surgical therapy in my office and immediately within a week came back with a periodontal abscess. I'm sure you've seen cases like this. I could have easily gone in, non-surgical under anesthesia, of course, and cleaned it out, and that could have been the day. But I flagged this for a couple of reasons. Number one, to embarrass my hygienist, to tell, hey, this is what we need to avoid. But just to be able to be sure. So the right image clearly shows the chunk of calculus that was missed in many situations. So if this sort of thing happens, it doesn't matter whether you're using laser or not. This is a shameful situation to be in. And of course, after the calculus is removed, meticulous resolution happens as expected. So, going back to this case, once the non-surgical therapy was completed, then I brought the patient into orthodontic therapy. In other words, occlusion. So two major important things. Well, three. The patient owning the disease, number one. Number two, meticulous non-surgical therapy. Do not miss calculus. Do not miss calculus. And that's an important thing, whether you use laser or not. And number three, occlusion. The bearing of occlusion in periodontal disease could not be stated any more strongly. We tend to be very weak on that last part. So, got her into a stable occlusion. What do I mean by stable occlusion? Non-traumatizing. Occlusion that is harmonious relative to the amount of support that each and every one of the teeth have. And the added bonus was, patient didn't realize this, she had lip incompetence and just plain English. Not very pretty. And after doing this, her and the family said, wow, you look a lot better. Wow, this guy's treated you not just for the gum disease, but made you look good. So it's an added bonus. And eventually, my restorative colleague went on to splint those anterior teeth that were so weak. A porcelain fused to metal bridge was used to splint all those. And long story short, we got her down to this level. And only when we got her there, we embarked on the implant therapy. She was lost to follow up, and then 6 years later, she returned to my practice. And I was very glad to see that, take a look, significant amount of attachment loss, just like the other cases. But this is pre-laser era in my practice, at least. And even in the pre-laser era, I was able to pull this through, because of careful attention to details, meticulous principle. So you can see these teeth are splinted, occlusion was, carefully manipulated, then implants replaced, and she actually returned because she broke this tooth now. She, of course, could not afford to finish the treatment from financial point of view, so half the mouth was treated, but we sure went long ways just to test people to see how well you were attentive in the earlier part of this presentation, the quiz part. What is the staging and grading in this case? Let's look at that. 3 steps. This is what the AAP recommends. Step 1, 2, and 3. Step 1 is to assess the whole case by probing, assessing the radiographs, and so forth. Stage 2 is to establish stage, and stage 3 is to establish grade. So this is clearly periodontitis, not necrotizing, not systemic disease, periodontitis with a smoking component, which we'll come to. Generalized severe periodontitis. Stage, she's lost 5 or more teeth, so right off the bat, she's on the worst stage, or stage 4. And then grade, oh, she's a smoker. She lies. She says under 10, but I said, nah, the way you smell and stink, it's got to be more than 10. So I sort of upgraded her to grade C. So this is how we communicate these days. This patient presents with generalized severe periodontitis of stage 4, with a grade 3. Giving this information not amongst us professionals, but to the patient as a significant educational component, because they need to know the staging. Just like when you pronounce somebody that you have cancer. Well, how bad is it, doc? Stage 4. How rapidly is it progressing? Grade 3. Out of the 3 possible grades, grade 3. Not good. You better act or you will lose all your teeth. That's a very different meaning to the periodontal diagnosis than what we were used to doing. So let's take a look at a couple of real cases. This patient, Connie, comes to my office. In fact, this was a referral via Millennia. She actually was a patient in my locality, And unfortunately, this lady went through twice classical osseous, flap and osseous procedure twice. She never liked it. You can tell by the amount of recessions and attachment loss, which is very commonly seen with the traditional flap and osseous. Nothing wrong with it. I've done tons of them in my first 10 years of being a periodontist, but now there's something better. I do them for pre-prosthetic management, crown lengthenings and whatnot. There are times I have to raise a flap to access certain regions and so on. But nowadays, I tend to do Lanap as a default almost. So when she said, there's got to be something better, I can't really do a flap surgery 3 times. So she looked around and she found Lanap. She called the company, and the company generously referred the patient to me. So I said, sure, I'll take a look. And this is the endpoint. Let's walk this through. When I first saw the patient, significant amount of probing, in fact, grade 3 furcation on the mesial of the upper left molar, a significant amount of exudate and purulence, lack of keratinized tissue, and attachment of muscle pole very much close to the pharyngeal margin, restorations that had a lot to be desired, rough edges, just making things worse. Now, of course, she had other issues. You can see, if you look very carefully, you can see the furcation arrow on this corner. You can see the furcation arrow on there too. Attachment loss was, here and there and everywhere. So that upper left molar was in trouble indeed. So I went through the fundamentals. Although I am applying the laser therapy, it's strictly LANAP protocol. I'm following that, but there's a few other things I wanted to emphasize. Do not leave those composite resins. They're irritants. They are part of the etiology. So during the first pass of this LANAP protocol, which is using laser at very high energy, introducing the fiber underneath the sulcus to the depth of the pocket, which not only sterilizes the area, kills the bugs, but it actually softens the calculus. But in this case, simply smoothing, and I even warned the patient, you might lose some of these fillings and some of them may have to be redone. Many times they are not necessary. Many times. So the restorations were adjusted accordingly, and they gave me a free ability to get to the bottom of the pocket. Then we went to the palatal side, where she had equally deep pockets, and in this case, this is an external bevel gingivectomy. So I'm sort of deviating away slightly from the LANAP protocol. I quit getting into trouble from the company, but that's okay. It's not the first time I got in trouble from them. I do a gingivectomy, but this is not simply for the sake of getting rid of the tissue, not just simply for the sake of resection. I'm utilizing this tissue because I want to reinforce and bolden the facial aspects. So when we do this, it just makes, instrumentation a lot easier, and access and laser and instruments a lot easier. What do we do to enhance the healing? This is platelet-rich fibrin. Everybody's using it now. If you aren't, I highly recommend. This is something we shouldn't be, hiding from the patient. We should be promoting this. Platelet-rich fibrin enhances the speed of the healing, and you can see where this went to now. The gingival graft that came from the palate, free graft in a sort of a cynical way, and in true term, free because it was freed up, and it's free because it didn't cost me. So the free gingival graft increases the depth of the vestibule, thickens the keratinized tissue, protects the wound and gives it a seal effect, but also it actually was able to get the patient to be able to brush the area with a little bit more confidence. So you can see the before and the after, and in case you're not too sure what a pocket is, this is not acting. I'm not very good at acting. You can ask my wife. You probe, and there's no bleeding, minimal attachment loss. Well, there is attachment loss, but minimal pocketing because we have some long junctional epithelium regenerated. Let's take a look at this young lady. This is Depti. She comes in. She's an attorney, young, intelligent, pretty attractive woman. She comes in with her husband. Her husband happens to be a physician. Between the two of them, they had traveled between 2, if not 3 periodontists, and they've all heard the same verdict. Those front teeth are coming out. She was traumatized psychologically, and she was just not accepting it, and she was in tears. So when I looked at her, I said, let's give this a try. This was not an easy call because there are several things. Significant amount of attachment loss, more than 5 millimeters, sure. Stage 4. Occlusal trauma, yes. She had mottled enamel, so she had a lot of restorations in the past, but double whammy. Look at the quality of the restorations, open margins, the color. It was just a nightmare. The long story short, this is before and the after of her pocket presentation, before and the after side by side, and we were able to manage the pockets extremely well. That lower left molar was not, I mean, no laser can treat that, so that one was slated for a dental implant, but the rest of the mouth, and this is actually the image, actually on the day of my Lynette procedure. So if you can bear with me, you will see that the probing is horrendous. We are probing sounding somewhere in the 9 to 10 millimeter. That's a UNC 15 probe. So you're witnessing something to the effect of say 8, 9 millimeters all the way to 12 plus. And you can imagine the looseness of the teeth. If I can demonstrate, yes, that's mobility 2 or 3. Some of them or those teeth are intruding. And you can see the attachment loss on the lingual aspect and the depths of the attachment loss, which is very, very prominent. So, and then what is this? Okay, I'm going to pass through. Okay, there's a lower molar. Just same redundant information. I'm going to speed up a bit. This is just to graphically show you how the laser fiber penetrates. The redness is not the real laser, it's actually a pilot light. So the operator has a pretty good idea of where the tip of the fiber is. In fact, the laser is invisible to naked eye, so you cannot see it, but that's why they introduced the red beam as a pilot, so we have a fair idea. And sometimes when you see that, I can see the outline, I can sometimes see the morphology of the bone, whether there's buccal bone or not, is sometimes visible. And you're aiming right for that bone at the crest, and you're trying to stimulate the bone, get rid of the calculus, all of those things. Now, this one, not only did it require a good occlusal therapy, which honestly I was not confident enough, it requires some follow-up restorations. She wanted no more, no less than beautiful anterior teeth. So I had to recruit a prosthodontist, and Dr. Jim Michael O'Brien, a brilliant prosthodontist in my area that I work with, he did all the post and pre and post-operative occlusal work. First, put the patient in hard, stable, night guard occlusal splint. Make sure all the occlusal parameters were checked. Now, during the surgery, I did something which is, again, slight deviation, off-label, should I call it, to the traditional LANAP protocol. I actually added some PRF. Platelet-rich fibrin was pressed and shoved into the pocket area because I just wanted a little more assurance. I do not want tissue to be shrinking at all, which is her desires. And you can see on the left image, a lot of the margins that were not visible in the past is now visible. Is that a concern? Yes, we expected it, but honestly, we didn't expect it to be this good. In fact, at this point, the teeth were stable. The soft tissue health. You can see the return of the pink coral nature of the tissue, stippling, the orange peel appearance. The edges are starting to go from rolled edges to be more sharper. So this is a few months after the LANAP procedure is done, and you can see the fact that the diastema that was present is now closed up. You can see something's happening. The teeth are stabilizing. The occlusion was checked, of course, adjusted, but the teeth are stabilizing. And I'm not doing justice to the restorative work because this is the best photograph I found, but I got to get the pictures from the prosthodontist. These restorations are now replaced, and they are looking immaculate. In fact, the redness here is not because of existing periodontal disease. This person, now that she saved the teeth and has beautiful restorations, she is a believer. She comes to our office every 3 months like clockwork. And this, I just happened to take these photographs on the day of her hygiene visit. And by the time I entered the room, the hygienist has already done some work, and that's what the redness is. So this is fairly recently. I can't remember exactly, but I'll show you the dates in a minute. So there's the implant replacement. This is a video showing the relative stability. She's in function. Look, she's moving left and right, front and back. She's doing that, and none of those front teeth are showing fremitus, which is an important aspect. So here I am. Again, no acting. My wife will attest to that. This guy's not a good actor. He gets busted all the time. So when you get the patient into full function, bite hard, grind your teeth, none of those teeth should be moving. And it's only at that time I felt comfortable. I sent the patient to Dr. O'Brien, the prosthodontist. He did a beautiful work, and as a result, we were able to bring this patient from a very, very uncomfortable situation to a happy camper. Now, both her and her husband are patients of mine, and we're treating them with joy. So here is the first step of the LANAP schematics, and the last step, and although it's not as drastic as in a lot of bone that regrew, but you will appreciate some of that bone has grown back, and attachment has changed, true regeneration. Let's look at some of the real significant changes. This is a case where a patient is about to lose that front tooth. The doctor that referred is a brilliant clinician. She does implants. In fact, I do implant training at different levels, and she went down to Mexico with me to get implant training. So she's one of those people who are very, very good at what she does. She said, "This looks like an implant case, a single tooth. Can you do a immediate?" And I said, "You know what? Let's try to see if we can save the tooth." So I prescribed this treatment plan: equilibration, splinting, non-surgical therapy, using laser, and then maintenance. And then the patient went back and discussed this option with the doctor, and the doctor said, "Oh, that sounds pretty simple. I think I can do that." So the patient went back to the general dentist. Nothing wrong with that, except she was a young patient, and that's why I felt that this was possible. Here's a little known fact: when lower incisors or the upper incisors are isolated in periodontal defect, and there's no history of obvious trauma such as accidents, baseball bats, car accidents, and things of that nature, then it's probably trauma from occlusion, because the lower and upper anterior teeth are the last teeth to be lost in the human mouth. We all know of people that's wearing full dentures, but the only teeth that they keep are the lower six. So what does it tell you? So I'm not about to give up lower six, if at all possible. So implants are last on my mind. Anyhow, patient goes back to the general dentist, and general dentist says, "See, I did all the things you told me to do, but I don't think it worked. You better see the patient again." So the patient returns to my practice looking like this. Clearly a lot more attachment loss, and clearly it doesn't look very good. So when I saw the patient, the lingual surface has a fistula tract with the inflammation just exudating out. Some form of splinting was done, and some sort of therapy was rendered. But when I checked the occlusion, it was a no-go. There was fremitus, in other words, movement when the patient bit down hard. Then, of course, the trauma is only going to exacerbate the inflammation. Furthermore, I looked at the splinting. The splinting was not much of value. It was fractured and split. So it wasn't truly serving the function. So at this point, I had to do quite a bit of fixing. I replaced the splint by putting some rigid stainless steel, wire. I eliminated the occlusal interferences completely, and then, only then, I was able to go and do the magic. Here's the Periodontist MBP7. The fiber is thinner than a periodontal probe, so you get the idea. And what you see is the charred tissue that, because it was already in use during the surgery, so the charred tissue should be scraped away, and the fine end goes in. Scraping, getting rid of the calculus is important. Leaving that clot of charred tissue is important, and this is healing at 2 weeks. I didn't do anything out of the ordinary in this case. 100% according to the LANAP protocol. These guys should be proud of me. So, healing at 2 weeks, healing at 4 months. It looks like we're going somewhere, but you can also see when the area is subjected to a lot of trauma, surgical trauma that is, albeit that the laser therapy is probably the mildest of all, but the tissue is thinning. So when the tissue thins, several things happen. As you can see, the tissue is delicate, so she's leaving some plaque behind, which is undesirable. When there's that much plaque, that means some of the bacteria and the anaerobes can enter the pocket area, reinfect the area, and also the seal is broken. So, and here, of course, because occlusion is the name of the game, we are placing the patient on a hard, I repeat, not soft, hard resin splint in the opposing arch, in the maxilla. Most people find the maxillary arch to be more comfortable. There's higher compliance. Also, the occlusion is easier to manipulate that way. So I like to put it on the maxilla. And at this point, I introduced the patient to my good colleague, Mary Chen, out of Hacienda Heights, and she does the endo. Because the apex was wide open, you can see the overfill of calcium hydroxide, which is perfectly fine. But this is very promising. The splint is intact. There's some form of regeneration that's evident. And so endodontic therapy and gingival graft is, taken care of at this point. And now you can see the difference. She's actually able to clean, and the hygiene is immaculate. She is on it. And as time goes by, we are seeing more and more of attachment returning. So here we go. This is a timeline. 2011, April. By the way, 2011 April, I had only just started laser. This was one of my first few cases. By December, by the time the laser treatment was rendered, and by December, we had some resolution. You can see that small piece of the bone, although the apex is still open, is starting to come back. We introduced gingival graft, and around this time, endodontics was carried out about a year into it. Now we're starting to get apical regeneration. And then at this point, a couple years later, now we're getting bone back on the mesial. So this is the way she presents more recently, before and after. And this is 2018, 2 years ago. Look at that. In the span of 7 years, she almost grew all of the bone back. It's not ideal, however, it's maintainable. So by the time the next patient came in with very similar presentation, I think I'm pretty good at this now. So when Tina came in, she came with virtually the same history. She was seen by 2 periodontists and 1 oral surgeons. And I think most of them recommended 4 incisors to be removed. There was a suggestion of maybe do a bridge from canine to canine. One of the clinicians said just take out that single tooth, but a lot of them were leaning towards, yeah, the other teeth aren't good either. So what do I know? Having done a couple of these, I said, Tina, let's save them. Of course, she was ecstatic. Rigid splinting. Block out the area, edge, splint, instant orthodontics. The teeth are pushed into the right occlusion. Create enough hygiene space so she can be able to maintain this in the long run. You can see this is all before surgery, so she still has calculus. We haven't gotten there yet. I just want stable occlusion first. Now we introduce LINAP, the laser fiber going all the way to the apex. And you guessed it, at some point we did endodontics, and I didn't want to commit to it until the initial progress was decent. So at 3 months, I introduced this patient to my good colleague John Lees, a great endodontist in Garden Grove, in the same building as myself, by the way. And this one was much more rapid in terms of return of the attachment. Take a look, nothing there, and we're seeing some signs of regeneration. And in 5 months, it's starting to solidify. And not quite a year, we got almost all of that tissue back. And 2 years later, she's stable. And you guessed it, gingival graft. Gingival graft. That is important because that deepens the vestibule. Even having, despite all that calculus, which is rather not that easy to miss, we still have fairly decent seal that we're looking for. So at 2 years out of it, we have another winner. Maybe this is the last case, a kind of a more complex case. Let's put everything together. Not all patients come with isolated situations. This Joanne, I hope she's okay. She travels back and forth between upstate New York and California, so I don't know where she is. I hope she's doing well. When I saw her, very intellectual, very charming lady, but somehow, life happens, and her mouth fell apart. So this was a kind of a very, very complex. Third molar, retained third molar, so upper left Posterior molars are going to be lost. Isolated areas of defect. We talked about orthodontics. She was not into that. She said, "Oh, at my age, orthodontics is not the thing." But there's a lot of mucogingival defects. A lot of the area that's unhygienic, very difficult to access. So, in this case, we bring everything out. Gingival grafting. This was all done on the day of the Lannett. This is actually acellular dermal matrix utilizing platelet-rich fibrin to deepen the vestibule. And after a couple of years, you can see that the tissue has recovered from the recession. Tissue is thicker, it's more resistant, and the vestibule is deeper. Muscle pull is taken away. Same thing on the lower arch. You can see there's no vestibule here to speak of. The pharyngeal margin and the mucosal tissue is the same. And after the therapy 2 years later, we've got some attached tissue regenerated. We've got some frenum pull pushed out of the way. And a couple of teeth that were a little too late coming to my practice, extracted. The socket is managed. The socket is grafted. And once it has healed adequately, I use my good old buddy, Professor Son's technique called the H-piece technique, which is a basically hydraulic lift using a piezoelectric surgery device. So this is right before the surgery. The socket management has helped me. A very conservative way of doing a sinus lift. Bone is pushed up, a couple of Straumann implants are placed fairly parallel, and the case is completed by Dr. Maria Kim, the restoring doctor, and just beautiful outcome with perfect occlusion and nice sinus lift via Crestal method. So doing that in conjunction with Lannett, all of these implant therapy, soft tissue therapy, occlusal therapy, meticulous maintenance, keeping the patient in good old night guard maintenance, all of this is important, not just buying the machine. And of course, these Millennium people do a magnificent job. Their protocol for training is just out of the world. Of all the training programs out there, I think they have one of the most extensive ways of doing it. So they do make sure that you get the right training. Not to mention the quality of all the instructors there. A lot of my colleagues are teaching that program, and nothing but hats off to these guys and gals. Grace, this is my real last case, I'm sorry. Grace, she presents a direct, straightforward referral for a single tooth implant. I saw the patient in 2017. I looked at that, and sure enough, there's attachment loss, furcation, class 3, late 2 furcation. And yeah, that's probably an implant case, but I had frank discussions, and the patient said, if there's a small chance I can save this tooth, let me try that first. I said, more than welcome. Let's give that a try. So here we are. Look at that. Again, UNC 15 probe. So that's about 11 to 12 millimeter probing, clinical probing. And then there is a significant amount of radiolucency. Here I cheated. I had to brace it flat because I could not rely on the classic laser Lannett protocol of non-flapping because there's so many other issues. And it was a good thing I flapped because not only was the defect so large, when you look at this high power, there's something that I want people to pay attention to. You've guessed it. Cervical enamel projection. There's a little bit of this enamel right there. And what it does, and most periodontists in the audience, the master's article that you have to kind of, learn off by heart in the perio board exams. Everybody knows all these numbers off by heart. Basically, they're there. They do not allow reattachment. So it's a great thing by luck, I flapped this and I was able to discover this. So what do? You put a burr to it and get rid of that enamel. And if I'm going to cheat, I might as well cheat all the way. So I actually added Emdogain and some sticky bone. So this is not the classic Lannett. However, I still give credit to the laser because there's no way we can instrument that sort of a deep defect without being meticulous. And there's no guarantee that all the bugs would be gone, all the anaerobes, all the gram negatives. So this is a sticky bone article that my group published a few years ago. This is a free journal, free online access, Dan Holtzko's journal. So you guys can access this and read all about this sticky bone method. So I'm going all the way. Get rid of the enamel projection. We used Emdogain. We used a laser. We put sticky bone in there, but I wanted healthier tissue, so this is connective tissue graft. And of course, I'm very nervous because if this doesn't work, it's not going to be a happy moment for all of us. But nonetheless, immediate post-surgical was kind of promising. You can't really see a lot of radiographic changes. What I do know is that there was a little piece of gutta percha that was spilled out that was removed. And it made me nervous because what if it didn't come out of the apex? What if it came out of the side? Is there zipping? I was pretty sure when I probed it, it wasn't zipping. So I still had some hope. At about 4 months, we weren't really getting much advancement. So then I looked at this and I said, look, Grace, you're getting a lot of gingivitis. And then I realized my mistake. I should have taken this at heart. The crown was over contoured. Why do you need to have that much porcelain and over contouring at the gingival margin there? Who cares whether it's white or dark? So with her agreement, I decided to do a plasty. Call it porcelain plastic, call it metal plastic, whatever you want to call it. I recontoured the restoration so that there will be hygiene access. Remember, this was all because plaque was aggregated there. And in doing so, after a couple of weeks, the pink coral gingiva returns. The patient can demonstrate. She can get the toothbrush down there. I couldn't be happier. She couldn't be happier. And as a result, after 2 years, we have saved the tooth, and we have saved the tooth from getting a dental implant. Every time I see her, I'm checking her occlusion. This is one method that I use, using occlusal indicator wax. And again, a video to show that where we are. Radiographically, there's still some scar, but when you probe, absolutely no probing from something that was approximately 11, 12 millimeters. What you see, there's a little bump, a little bit scarring, very, very small amount of gingivitis because it's still a challenge to clean. But imagine if the restoration was not contoured, how on earth can you clean there? So I'm really happy. Today, this is a very, very recent article talking about the effectiveness of the so-called modified BAS technique, BAS intrasulcular brushing technique. I thought people didn't do these kind of things anymore. I thought this was all done 100 years ago and we never looked back. This is a recent article. Kudos to the Tufts University Perio department who has pulled this through. And basically, this is a study that shows that modified BAS technique is much more effective in reducing bleeding and probing. So please have faith. Cases like this, create the environment, make that restoration cleansable, and teach the patient, give them tools as to be able to clean. And sure enough, we should be able to get the result we're looking for. Oh boy, I raced through this in just over an hour. So I have time to answer some questions if I can.
All right, Dr. Kim, thank you so much. One of the first questions that came in is, how much is enough when reducing occlusion, even on deep dentin exposure?
That's a good question. Prior to doing periodontics, I was a general practitioner for approximately 9 years. So I've done my share of occlusion. I've taken most of the classic courses, Dawson, Pankey, that sort of background. So I kind of have a basic idea of occlusion. But it wasn't until I got into periodontal treatment that I understood the occlusion. So in classic training, we were told to reduce, but it was very vague. Honestly, we weren't told that very detail. I learned how to reduce occlusion basically in the periolace training. And the periolace training is a little bit more aggressive. We're not talking about eliminating or reducing the interference. We're talking about just getting rid of it. Just get the burr and get to it until the interference is gone. Then people argue, but you're destroying the nice porcelain or the dentine enamel. You're starting to get, sensitivity. Let's put things into perspective. We're not doing this to a healthy tooth. We're doing this to a tooth that's about to be lost. So, things have to be put into the right perspective. So, is it going to create dentine sensitivity? Sure, you're going to have to consider that. And then you're going to have to consider, are we going to provisionalize it, maybe a full coverage resident restoration before we embark on this journey? If there is hope, if the prognosis is fair. Or do we, if it's a beaten up tooth in an elderly person, chances are you're going to get away with exposing dentine because of the sclerotic nature of it. So number one, Be very aggressive. Don't think that reducing interference is enough. You have to get rid of the fremitus. I hope that answered that part of the question.
Thank you very much. Our next question, in some cases you treat localized sites with laser and not using full mouth Lanap. In some cases you splint prior to laser therapy. So how do you make those determinations?
That's a very observant thing because yes, you're right. I have shown cases contradicting each other and so on. When it's a very severe looseness to the point where grade 2, grade 3 mobility exists, like in those single incisor, lower incisors, you can't start the therapy until the occlusion is stable, clearly. Some of the cases where the mobility is there, but it's not detrimental, we actually do occlusal therapy during Lanap. In fact, that's the bulk of most of the cases. Again, some of the cases that require splinting, we do it ahead of the time. Some of the cases that might not need splinting, but significant amount of occlusal therapy is needed, I do that as a separate procedure. Bring the patient in, do the occlusal therapy, try to see if I can get a stable occlusion before embark on the surgery, but the patient's also getting a hard occlusal splint. Now, the times that I may say you might need splinting, but let's see, many times it's the maxillary anterior because those are hard to splint. If it's, let's say, the bicuspids, which are again physically hard to splint, I may decide to splint with a very ugly facial splinting for a short period of time, or decide to do that even after the surgery. So that's my sort of a vague guideline. But the key thing is, if the tooth is that loose that it's uncontrollable, it's a good idea to splint before.
Thank you again. I really like this next question. It's one we actually hear quite frequently. Do you retreat laser treated teeth? And if so, when?
Oh, that's a very good question. In periodontal therapy in general, be it surgical or non-surgical, you always have to have the back door open because there's no such thing as cure, and there's always a possibility of retreatment, independent of what treatment modality that we employ. So we're very aware of that. My experience with Lanap is I've had hardly any full Lanap that I had to repeat, knock on wood. I've had partial, the areas, couple of bicuspids breaking down and so forth. I've had to do that numerous times. The number one area, I must say, is a second molar. Second molar, conical roots, heroic type of regeneration, breaks down again. Hygiene is hard, occlusion is hard to control. And I've had maybe several cases I've tried once, twice, and then ultimately said time for an implant. So that is a possible likelihood. But in the bicuspids and the anterior, very rarely do I lose the teeth and we have to go to implants.
Thank you. And we are running a little bit short on time. Let me ask just a couple more quick questions.
Sure.
Thank you. There's been a request for you to expand upon your answer of when you would treat local versus full mouth.
This may not be an easy answer on this one because it's very rare. Let me divide the talk just for the sake of not miscommunicating. In general, if it's a new patient to my practice, I rarely do localized. Most patients who are new to my practice, and not to disrespect the referral, most of the time that by the time they come to my office, it's at least moderate to advanced situation. So despite what the therapy was in the past, I can only control the case by full mouth treatment, making sure that none of the areas, no teeth left behind, making the overall occlusion is controlled and so forth. So I usually go that direction. If it's somebody that I have treated or has been in my practice for many years and isolated areas are breaking down, clearly that could be a limited or partial area. But Lanap, by definition, and this is the company protocol that I'm speaking on behalf, Lanap by definition is a full mask protocol. And you really can't control the occlusion sometimes when you do partial therapy. And my experience has been, now that I've done several hundred of these cases over the past 10 years or so, there are times when I say, did I really push this one? Maybe we could have just worked on this one quadrant. Maybe the other quadrants, maybe we can got away with some scaling and root planing. But most of the time I do things under anesthesia, general anesthesia, or deep sedation. And many times when I go to different areas, to my surprise, I say, you know what, that was a good decision because I missed that 5 mm with a very narrow defect there. The furcation involvement, I just missed that too. Very, very common. So I think I'm going to stick to this. I think it's to the patient's benefit. This is not an over treatment by any means, because we simply don't know until we go in there and sound things. And let's face it, on a brand new patient, I don't probe as hard. I don't want to make a bad impression. I don't want to hurt them because whether it's a 5 or 6 doesn't matter because I know the overall condition. But that method of underestimating could burn us if we don't do comprehensive treatment. So I hope there's some grain of pearl there. Can I add this, Rachel? I see the list of questions is huge, and I kind of feel guilty not being able to answer all the questions. If you don't mind sending me the questions, and what I'll do is I'll try to email back some of the answers to my best to the participants because I know everybody had tons of questions, and there is a limitation of time here.
Thank you very much, Dr. Kim. I will send you all the questions, and thank you all for attending. As Dr. Kim has mentioned, we will answer the questions that we are able to, and when you registered, you did provide us with their email, so that is the email that we will send the answers to your questions today. A quick reminder, you will receive an email about an hour from now that has a form and the redemption information for your CE. Once you complete that form, we will email you your CE within 2 business days. We do process these by hand, so if you have any questions, please just send an email, and my email is also on that confirmation. Additional webinars are available for those who would like to learn more at lanap.com/webinars. And the Periodontist periodontal package from Millennium does include the Periodontist MVP7, as well as 5 days of the training that Dr. Kim mentioned, with live patient procedure training as well. That is required to become LANAP certified. There is a special economic stimulus pricing on the package for a limited time, and if you're interested in more information on that pricing, please contact your rep or call us at 888-526-2749. Thank you very much, Dr. Kim.
Thank you very much. Pleasure.